but I cannot see your options to share your microphone and your camera, Namar.
I've just done it. I think...
Maybe it's because you have access using...
Okay, good evening and welcome to the Baxter SCTS seminar. Firstly, I'd like to thank the SCTS for enabling us to be able to meet on this virtual platform. We have two fantastic talks from our expert speakers tonight on managing intraoperative bleeding to maximise patient outcomes in these challenging times. I'm sure our speakers need no introduction. Professor Alatar is a consultant cardiac and transplant surgeon who works at the Golden Jubilee National Hospital in Glasgow, Scotland, and is the director of the Scottish National Advanced Heart Failure Service. Professor Ulrich Stock is a consultant cardiothoracic surgeon based at the Harefield Hospital in London and is a senior lecturer at Imperial College London. We will have time with the speakers after the presentations for questions, so please post any that you have using the Slido platform. We will aim to answer as many as possible after the presentations. So I'll take no more of the time, and if we could move on to the first presentation from Professor Alatar, please.
Thank you. My talk will be on the impact of bleeding on our outcomes, with a particular focus on our practice during the COVID-19 pandemic. These are my disclosures. Now, bleeding has two main clinical surrogates. The first is blood transfusion. And we know from the work by Gavin Murphy et al. Many years ago that the proportion of patients dying after surgery is significantly higher in patients who required a blood transfusion compared to those who didn't. And that is not unexpected. These patients have suffered from a complication that might compromise their overall recovery. However, what's really interesting in this paper is the fact that this effect on survival is persistent. There's a higher proportion of patients who die for 7 years, which is the duration of follow-up, in the group that had a blood transfusion compared to those who didn't. The explanation of that might be the fact that blood transfusion is like transplantation. It has huge benefits, but there are potential consequences to it. The other clinical surrogate is reopening of the chest for bleeding, and indeed patients who do need to go back to theatre for re-exploration of the mediastinum have a much lower survival than those who do not. And this is regardless of whether the revision was successful or not. In this large cohort of over 20,000 patients, the transfusion group had a higher all-cause mortality, a higher rate of postoperative infection, and were at higher risk for reintervention and a prolonged stay in hospital. And while massive blood transfusions, 10 units or more, are associated with a huge increase in the morbidity and mortality, that's understandable. This is a catastrophic bleeding event. What's really intriguing in this paper is that the transfusion of only 1 or 2 units of blood is associated with around a 40% increase in the odds ratio for both morbidity, for complications, and for death. So bleeding comes with some potential risks. The question then is, by restricting blood transfusion, do the outcomes improve? Is it safe? And it's exactly what this group of surgeons in the US attempted to answer. And they divided their patients into 2 categories. The first one were those who had standard of care, and therefore they were transfused in a more liberal manner. The second group, they applied a more proactive approach by correcting preoperative anemia, by minimizing blood loss with meticulous surgical technique, the use of hemostats and cell saver, and by tolerating a degree of postoperative anemia. And here are the 2 groups of patients. So this is a familiar number of transfusion in cardiac surgery, and about 40% of patients had standard of care and therefore had a blood transfusion. It was only 11% in the restrictive strategy. But what you can see, and what's really interesting, is a threefold increase in mortality and more than doubling on complication rate in the liberal transfusion strategy compared to the blood preservation or restrictive strategy. And this has been shown time and again. This is another study where restrictive strategy had a better survival compared to a liberal strategy in all patients. But even when stratified to age and to the Apache 2 score, we could see a similar finding. So better survival with restrictive strategy. Now that clarifies the impact of bleeding and outcome. Patients who bleed have a poorer outcome. But we also wanted to look at the impact of bleeding on resources, and in particular, the use of critical care beds and the length of stay in hospital in patients who had cardiac surgery. This study was done just prior to COVID, and you can see that patients who bled had a longer critical care stay and a longer hospitalization. And when we looked in detail into the different types of operations, we noted that, be it surgical revascularization, valve surgery, and even more in aortic procedures, the impact of bleeding was a significant increase in critical care days, as well as the length of stay in hospital. It was quite remarked for aortic procedures, and I'll come to discuss that in more detail later on. Now, to try and put a figure on the cost of reopening was what this group in Sweden attempted to do. So they compared patients who had a CABG procedure. They compared a group that had to be reopened to a group that didn't. And they identified a figure of around 6,000 euros of extra financial burden, of extra financial cost per procedure when a reopening was required. This was all prior to COVID. At that point, bleeding was a problem. At that point, there was pressure on beds, particularly in intensive care. So you can imagine, obviously, with the advent of the pandemic, with the virus, this was compounded to a great extent. The pandemic resulted in a huge disruption to surgical activity all over the world. It affected, of course, not only patients, but people in general. But there was further pressure on hospitals and the healthcare system in particular. It's only recently that we know that these patients who do develop COVID should not have an operation for at least 7 weeks or 8 weeks after the COVID infection, and it's only after that time, after 7 weeks, that the survival rate comes back, or the risk of postoperative death comes back to patients, to that comparable of patients who have not suffered from the SARS-CoV-2 vaccine. We had to look at our own experience in Glasgow, and we audited patients who had surgery before and during the pandemic. There were a number of interesting findings, besides, of course, the drop in activity, which I think is something we all witnessed. There was fewer patients who were women who were operated during the pandemic. So fewer women had surgery during the COVID-19 pandemic compared to the pre-COVID state. And the reason for that still, to me, is a bit elusive. Furthermore, we noted that our patients' Euroscore was significantly higher, statistically higher, during the pandemic than pre-COVID, and we were doing more and more patients in an urgent or emergent manner. The repercussions of that was that patients were staying longer in intensive care, and that the ventilation times were prolonged compared to pre-COVID, and this reflected in an overall hospital stay that was significantly longer than in the pre-COVID era. This added a further strain. Already, our staff was required to cover COVID-related activities, although we were a COVID-limited hospital. But speaking on a more general basis, the pressure on beds obviously was clear. This added further strain on our resources. We had a flourishing ERAS program prior to COVID, but as you can see, significant dip in achieving our target of moving patients from critical care to the ward and getting them out of hospital within our target time frame. The date of surgery admission program stopped altogether, and it's only now that we are restarting DOSA patients. I'm sure many of you relate to what I've just said, and you've experienced to a great extent what we have. But this is an interesting study from France where they had an even greater drop in their activity during COVID. Similar to us, they noted that fewer female patients were having surgery during the pandemic. The Euroscore almost doubled, and you can see they had a much higher mortality rate on the patients that they operated on during the pandemic, with a huge jump in their complication rate and their morbidity, the morbidity numbers. On top of that, those pressures, there were these worrying headlines of blood shortages. And although we were operating less in numbers, the patients being of a greater risk, and I suppose compounded by the fact that people in lockdown weren't coming forward to donate blood, resulted in shortages of particularly certain blood groups. And there's no doubt that bleeding is the main complication of cardiovascular surgery. It's an inherent and innate complication. And the reason for that is because the way we perform our operation, I'll come to discuss that in more detail, but we obviously perform it with a significant degree of heparinization. We use extracorporeal circulation with all the ischemic reperfusion injuries and inflammatory reaction that the blood flowing through the tubes and the oxygenator will result in. Hypothermia is an issue for us, and of course surgical experience. But also there are factors that relate to our patients, and the fact that we operate on dystrophic tissue that's fragile and can tear easily, and the fact that many of our patients are on blood thinners. During COVID, we demonstrated that more and more of our patients are done in a more urgent manner, and that lack of the opportunity to optimize patients obviously entered into the equation. In this slide, I just quickly want to review hemostasis, and rather than showing the coagulation cascade, this is a more practical model of hemostasis. So when a vessel is injured, the first thing that happens is that platelets are activated and they form a platelet plug. But when patients are on antiplatelets or dual antiplatelets, then of course that platelet plug is of poor quality and insufficient to stop bleeding. The next step would be the generation of thrombin. So thrombin would come on and create a thrombin plug. However, again, with hemodilution, with hypothermia, with metabolic derangements, that initial clot is quite weak. And the ultimate step in clot formation is the formation of the fibrin mesh, which consolidates the clot and secures it, preventing rebleeding later on. And then again, similar factors, as well as, of course, the fibrinolysis that would that's part and parcel of this process, could mean that what is already a flimsy or weak clot will break down, and the risk of rebleeding is therefore high. It's no surprise to all of us that when we perform surgery in cardiac pulmonary bypass, the first thing we do is to inject 1.5 liters of priming solution, which results in considerable hemodilution of blood, of platelets, of clotting factors, and that obviously has an impact on the ability to generate clots. And the fact that we do run an extracorporeal circulation with activation of different factors also enters into the equation. We anticoagulate aggressively. In fact, this is the highest dose of heparin given in medicine, and we do it to achieve an ACT above 400 seconds. Our patients almost invariably are on at least one, and if not two, antiplatelet agents, and we know that dual antiplatelet therapy is quite effective, really, in inhibiting platelet function. And obviously, that's our first and crucial step in formation of the platelet plug and stopping bleeding. Presence of or the advent of DOACs or NOACs, the novel oral anticoagulants, is a particular challenge. Again, these products are incredibly effective in preventing clotting, and furthermore, unlike warfarin, for which vitamin K was a readily available antidote, the same cannot be said for these products. When performing procedures under hypothermia, we know that the need for transfusion of blood and products is much higher, and that obviously is explained by the fact that enzymatic reactions that are required to start the coagulation cascade are inhibited by hypothermia. You add to all of that COVID, and although COVID has had the reputation of causing more clotting issues, this interesting paper from the US that has just recently been published has shown that, in fact, in critically ill patients, there's a similar rate of bleeding, similar in fact to thrombotic complications, and it seems that high D-dimer levels at presentation are a predictor of these bleeding and thrombotic complications, and also of a poor outcome. So what we want to do is break this vicious circle. This is what I call the spiral of doom. With a coagulopathy, we get metabolic derangement, and we require transfusion of blood and blood products, resulting in hypothermia. We need to break this the cycle before the patient dies, and we do that by preserving blood, keeping blood in the patient, stopping bleeding, and stopping this cycle of doom. And there are, of course, this involves all members of the team. The patient bleeding management starts before surgery and involves not only surgeons but all involved in patient's care. But I would want to focus on the use of hemostats to help with intra-operative bleeding. This slide shows a few examples, and there are many more, but I would like to talk about two in particular. The first is the fibrate sealants, and these mix thrombin and fibrinogen to generate a clot, and it's that clot that we can apply on the tissue to stop bleeding. Of course, it should never be applied intravascularly because it will cause embolism, and should never be used when, of course, surgical technique is adequate to achieve hemostasis. It does have its limitations because these are biological products and preserved in frozen temperatures. There's a time factor that has to be considered while they're being prepared and thawed. As I said, they should never be applied in an open vessel, as one, they can enter inside the vessel and cause clotting, and two, they can be washed off with brisk bleeding. One should also be careful about removing them, as they can indeed stick to the gauze or even surrounding structures in the pericardium. They can be sprayed, and this is a way of achieving application over a wide surface. But then again, it's important never to spray them on an open vessel, and to avoid, of course, the use of air or oxygen, but only use CO2 to minimize the risk of gas embolism. The other type of hemostats I'd like to talk about is the gelatin thrombin matrix product. Now, these are made of, the active component is thrombin, and there are particles of gelatin within that product. When mixed together and applied on a bleeding point, the gelatin swells, the thrombin activates, and they help generation of a clot. Therefore, they are absolutely of no indication whatsoever if there is no bleeding. In the absence of bleeding, they have no role to play. But when bleeding does happen, they can certainly contribute to help form a clot formation, particularly in patients who are coagulopathic. Again, they do need about a minute or so for preparation, and they can be washed away with brisk bleeding. There's an element of swelling, and that should be kept into consideration when they are applied in confined areas. So I thought I'd share with you through a number of clinical scenarios how best to apply them in patients at high risk of bleeding. And what first comes to my mind is obviously surgery of the aorta. And the reason aortic surgery has a greater risk of bleeding is because the procedure itself, the technical aspect, often involves extensive dissection with multiple anastomosis. The intervention being prolonged, therefore, has a longer run of cardiopulmonary bypass time. And depending on the extent of the repair, we often need to cool the patient significantly, particularly when circulatory arrest is warranted. On top of that, we operate on dystrophic and fragile tissue, and you can appreciate each and every single needle hole is therefore a potential site for bleeding. The aorta is replaced by a prosthetic material, and the tube porosity is an issue. The tubes themselves have no inherent ability to stop bleeding, and if the coagulation system is deficient, then bleeding can be a problem through them. Many of these interventions are done in an urgent or an emergent manner. And again, that takes away the opportunity to optimize patients or neutralize the effects of any antiplatelets or anticoagulants they may be on. So what is my approach? So obviously, surgical technique primes, but when faced with procedures like this, I use what I call the George W. Bush approach. And what I mean by that is I would strike first. So I would apply a sealant in a preemptive manner. I would do it in the areas where I would suspect that bleeding could happen, so particularly around the prosthetic tube, and I would do it where surgical access could be complicated once the operation's over, for example, over the coronary buttons particularly. So I would apply a film of sealant. This would protect these holes. It would minimize, limit, or even prevent bleeding to a great extent. And indeed, once the cross clamp is off and everything is dry, well, then it means that there should be no further delay and we can proceed with the second patient or go home. We can also expect that the patient has an eventful recovery. However, if bleeding does follow despite the application of sealant, then indeed the first step would be to address it surgically. But when conventional techniques are insufficient, then the use of thrombin gelatin matrix can really alter the course of that operation. These products have an active prothrombotic effect. So once in contact with that bleeding point and in contact with blood, they will activate and they will result in the formation of a clot. And that could really make a difference on the patient's overall journey in theatre. They will stop the bleeding and allow us to progress the operation. In bypass surgery, the use of hemostats is less frequent. However, in situations where there is extensive dissection of the myocardium, then the use of these sealants can mean that bothersome bleeding will stop. And in long, difficult anastomosis, particularly with endarterectomies, then protection of these needle holes with a hemostat can also mean minimal drainage after the procedure. This is why a couple of years ago, the European Association of Cardiothoracic Surgery and IACTA recommended the use of sealants in patients where there was a risk of bleeding, particularly when conventional techniques failed to achieve hemostasis. Now, bleeding concerns each and every member of the operating team, and communication, therefore, is key. There have been attempts to try and define perioperative bleeding in surgery, but one of the best scales to enhance that communication between team members and to identify a bleeding state and to quantify its severity is the VIBE scale. The VIBE scale, as you can see, goes from 0, where there's no bleeding, to 4, which is life-threatening. And that grade is a strong communication element to all members of the team that bleeding is an issue. And it also can help justifying the use of hemostates because they do come with a cost. And this excellent study looked at the cost effectiveness of patient blood management. And what it demonstrates is that for each bleeding complication that's avoided, there's an economy of around 1,200 euros per patient, and around 5,000 per avoided death. And if you include all hospitalization costs, then that number goes up to 14,000 euros, over 14,000 euros per prevention of one bleeding complication. So there's a huge financial benefit in making sure that the patient is absolutely dry and that the risk of bleeding is eliminated. So to finish, I'm going to tell a joke. When patients bleed at the end of their operation, the first thing we will often apply the 5P approach. And this starts off by compression, pressure on the bleeding site, hoping that it stops. When it doesn't work, we'll ask the anesthetist to give a bit more protamine because we think it's the heparin that's driving the bleeding. When that doesn't help, then it's often transfusion. Give me some plasma and some platelets in the hope that that will stop the bleeding. Whereas my anesthetist will often say, what you really need to use is proline. And there's no doubt that a surgical suture is indeed the first and foremost, and if not the best approach to stop surgical bleeding. But when it fails, when conventional surgical techniques only result in more needle holes and further bleeding, then the use of hemostats can really make a difference. They are a fantastic adjuvant, a fantastic tool to achieve hemostasis, particularly in patients who have coagulation, who are coagulopathic, who have coagulation deficits. I've shown you my strategy of how to employ them preemptively before bleeding starts, or proactively using a flowable when it does. Our objective is that our patients do well after surgery and that outcomes are the best they can, but we also, by avoiding these bleeding complications, which are indeed the main complication of cardiac surgery, we reduce costs, and hemostats are a great adjunct for that. What would be fantastic would be for all our patients to feel so well and to mobilize very quickly after surgery. This is a patient who's had his bypass. I told him we are putting you on the ERAS program, and he wanted to show that he's already mobilizing. He's not even extubated, but he's already mobilizing. Yes, there's no bleeding. He wants the tube out, and he wants to go home. Thank you for listening to me.
So, thank you, Professor Alatar. It's fascinating for me and an eye-opener to see the effects even one transfusion can have on the patient and the legacy it leaves. So thank you very much for your insightful presentation. For the attendees, you will see there is a quick poll, so if you could take a second to rate the presentation, please, it would be much appreciated. We are running perfectly to time. As a reminder, if you have any questions for the speakers, please post them on the Slido platform, and we will look to answer these at the end of the next presentation. Can we please move to Professor Stock's presentation?
Welcome, everybody. It's a pleasure to be part of this Baxter webinar, and I'd like to talk about COVID patient challenges in cardiothoracic surgery. Looking at the numbers, last year in May, we had 250,000 cases and about 36,000 deaths recorded in the United Kingdom. If we now look 3 days ago, on the 27th of April, we had 4.4 million cases and 127,000 deaths recorded in the UK. Quite dramatic changes, and of course it impacted our entire life, the professional life, but our normal life as well. So of course, the first surge was okay. This is a publication by my colleague Hasiba Smile, a surgical colleague here in Harefield, who looked at the impact of the cardiac surgery on COVID on cardiac surgery during the first surge, basically from March till May last year. And she named it the cardiac surgery from vita minima to recovery, as we all observed after the first surge, a slow but constant recovery till we were all hit by the second surge. We were quite impressed what we could achieve in the first surge, as we all know that in London there were only 2 hospitals available and allowed to do and continue cardiac surgery. It was Barts and Harefield Hospital. And we were quite proud that despite limitation to only emergency surgeries, we achieved CABGs, and we even achieved 3 LVAD urgently needed patients waiting for a heart transplantation who didn't have a chance to get a heart. However, we accomplished heart, lung transplantation, and even a quite emergent excision of a cardiac tumor. In summary, my colleague, Ms. Smile, summarized after a phase of justifiable caution, and we all know that it was quite scary in the first case, in the first surge, and falling demand, we have developed a system for safe surgery, which may be of value to others. And of course, it was of value of others during this extraordinary situation, and we had this metamorphosis, what is now being referred as the normal. And I believe we all agree, right now we have these special measures with a double swabbing. Patient needs to isolate, try to isolate for 2 weeks prior to admission in the hospital. We have different pathways, recall, inherited, and then the green, the amber, and the red pathway for patients with high risk, of low risk, or no risk of COVID infection. So we kindly survived the first surge. We even survived the second. Of course, the second was quite more difficult. And here you see some kind of the dramatic situation in between January and February this year, when we had almost 8,000 patients in London in hospital, and we had a considerable number of 1,500 to 1,600 patients on a ventilator in the London area, basically really making our life and the cardiac surgery life quite difficult. The bottleneck in everything is the critical bed situation. We are proud about getting sponsored by another Royal Brompton Hereford charity ITU bed. These beds were double occupied, so we had in a single bed 2 patients. And of course, the care for the COVID patients with proning and the entire care was really quite difficult and limiting our ITU capacity. In the end, the entire Hereford cardiac surgery was limited to 5 ITU critical care beds. And of course, it is not only in Hereford, it's all over in the UK. And of course, we are not very proud. We are proud what we accomplished, our pragmatic approach to overcome the COVID pandemic with vaccination, for instance, but I believe we can't be really proud about the ITU and critical care bed capacity in the UK. It's increasing, and I'm quite confident that it will increase over the next years as well as a learning point from the COVID pandemic. But if we compare UK with Germany and the United States, it's quite appalling that we are far behind. I'd like to now come to a little bit more optimistic, as we believe we have good reason to be optimistic that we overcome the real COVID issue, hopefully not with a third surge, but let's focus on the positive things. And I'd like to introduce you to a very nice paper published in the Thoracic Surgical Clinics by Cousteau Voltaire. And the title is How to Swim with Sharks, a primer. You might ask, well, what does swimming with sharks has to do with cardiac surgery? Well, interestingly, this was not even designed for some kind of normal swimmers. This essay was written for sponge divers. And if you look at the foreword, it's quite interesting because you will see some kind of, you will find yourself again in his description of what to do, how to do. As actually nobody wants to swim with sharks. It is not an acknowledged sport, and it's neither enjoyable or exhilarating. These instructions are written primarily for the benefit of those who, by virtue of their occupation, find they must swim and find that the water is infested with sharks. So I'm not talking about colleagues. No, I'm talking about the problem of bleeding. So for surgeons, we all know that we don't like bleeding, but it's just part of our daily routine, and we need to face it. We might not like it, but we need to work with bleeding. So Voltaire wrote down a couple of principles. And the first principle is a nice one: do not bleed. It's a cardinal principle that if you're injured, either by accident or by intent, you must not bleed. Tell the patient. Experience shows that bleeding prompts an even more aggressive attack and will often provoke the participation of sharks that are uninvolved or, as noted above, are usually docile. Translated to our daily routine, we should avoid excessive bleeding, as excessive bleeding will result in even more bleeding, likely extending ITU and in hospital stay. And there are 2 basically words which we need to highlight. It's bleeding and ITU. And with this extreme restriction during the COVID pandemic, the extreme restriction ITU capacity, every single patient on the ITU counts. So if you have a delayed ITU recovery, delayed extubation, this is going to be serious issue for some kind of piling patients who need some kind of urgent surgery. Voltaire's principle number 2, admittedly, it's not easy not to bleed when injured. Indeed, this might be impossible. However, now it's important, diligent practice, and I will come to it in a moment when I present 2 cases. The diligent practice, however, will permit the experienced swimmer to sustain a serious laceration without bleeding and without even exhibiting any loss of composure. These hemostatic effects can in part be conditioned, but there may be constitutional aspects as well. And now it's important, those who cannot learn to control the bleeding should not attempt to swim with sharks, for the peril is too great. I translated, the one who opens dry will close dry as well. It's an old surgeon's saying. Look outside the UK. This is a very interesting publication from Tom Nguyen. He presented at the 57th annual meeting after the SCTS. And so he looked at the numbers of cases and the decline of cases through the period from January 2018 till June 2020. With a 53% reduction of the average monthly cardiac surgical volume. But what is most important is that the emergency cases dropped 40% in non-elective cases. So emergencies is 40% drop compared to 64% decrease in routine cases. Liverpool, the aortic program, published a nice paper about the perspective from the United Kingdom. They focused on aortic surgery. And of course, their activity during the first surge dropped dramatically, recovered round about July in order to shortly after decline as well and go into the second dive for some kind of recovery. Now I'd like to present you 2 patients. This first patient is a quite complex patient, and you see some kind of a lot of piping, and I'm going to go a little bit more in detail. It was a 21-year-old female, 160, 51, lightweight, a young lady, with absolutely no medical history, no smoking, no drug abuse. On the 22nd of January, she experienced some chest pain on the bus in London. She went to the next A&E department. They wrote an ECG, and surprisingly, there were ST elevations in the interior wall. With a suspicion of an coronary artery disease, she was transferred to the cath lab, arrested in the cath lab, went on Lucas resuscitation. The angio revealed a scat of the left mainstem. They desperately tried to reopen the left mainstem and didn't really got it. So the LAD was still occluded under constant resuscitation. They failed to attempt an insert of femoral artery ECMO. And then in the end, they asked the cardiac surgeon to open the sternum, institute a cardiopulmonary bypass, and do a Lima LAD graft. Not surprising, after prolonged resuscitation, they were unable to come off bypass, and they requested the Royal Brompton Hereford ECMO retrieval team for support. The patient was in the end transferred in the night from the 22nd to 23rd on central ECMO with an open chest to Hereford Hospital. The next morning, we repeated the angio. It confirmed the left mainstem was occluded. We placed the left mainstem stent. However, the distal LAD remained occluded, and we couldn't really visualize the LAD, a distal LAD, not even through the Lima. And on the re-exploration the very next day, as patient was now under dual antiplatelet therapy, of course, she tamponated. We had to open the chest. The Lima was occluded. So not surprisingly, she developed a single organ failure. And with a single organ failure, we inserted a left side levatronics on the 3rd of February. She recovered. However, it was a quite complicated postoperative period. She had an acute injury, kidney injury. She had a critical illness polyneuropathy. She developed a hematotoracx requiring VATS, twice an open thoracotomy. She developed severe pneumonia. However, 6 weeks later, we were able to activate her on the super urgent waiting list for transplantation. Unfortunately, shortly after, she developed repeatedly fibrin deposition in her lines, requiring multiple exchanges. And then in the end, we had to decide to go for an upgrade to durable LVAD on the 20th of April 2021. So this is a picture what we had at the end of the implantation of the VAD. We see some kind of the imprints of the previous inflow graft, the outflow graft of the diaphragm graft stitched to the ascending aorta, and there was considerable bleeding. Of course, you now discuss about the treatment concept. So yes, we did a TEC. The attack was pathologic. Not surprisingly, our anesthetists were quite active. They offered 2 rounds of platelets, FFPs and fibrinogen. In the end, we even offered them the patient Novo 7. Nevertheless, she continued bleeding. We used lots of manual compression, didn't work out. Then we decided to leave the chest open. However, leaving a chest open with a considerable bleeding is not a good idea, because we all know what is going to happen overnight. It's going to be a bloody disaster on ITU. Remember, this is even so at the end of the surge, the second surge, still ITU capacity was very limited in the beginning of January this year. And then I decided to go for hemopatch, and this is the outcome after hemopatch application to the anterior wall. The diffuse bleeding stopped. You might say, was it only the diffuse bleeding because of the hemopatch? Well, of course, it was a combination. However, we controlled the bleeding on the anterior wall. Chest was left open. We transferred the patient to ITU. The next day, we closed the chest, and the bleeding was under control. So Voltaire's principle number 3, get out of the water if someone is bleeding. If a swimmer or shark has been injured and is bleeding, get out of the water promptly. Fast surgeon means treat bleeding promptly. Don't wait for protamine. Don't wait for a miracle. Now introduce you the second patient. It's a 53-year-old gentleman who, due to COVID, was reluctant to come to the A&D department. He had chest pain. It was a late presentation of a CTO with LAD. He went into cardiogenic shock after reopening of the LAD 3 days after onset of chest pain. He got an ECMO via the right subclavian artery, and then, not surprising, because he was under dual antiplatelet therapies in treatment, you see significant bleeding from the connector to the grout flow graft. Question, what can we do? Of course, we have some different options. Treatment option 1 is wait and hope for a miracle. Well, you won't be surprised. I don't believe in miracles in this particular situation. The second one is the so-called magic wrapping, where you place some cellulose around this area. You wrap it, you use some fibrin glue. It might work, but there one point, first of all, it might work. And the second part is that it doesn't really look nice. And if you consider that this needs to be in situ for a couple of days or maybe even weeks in order to get a heart for urgent listening, or for the patient who might some kind of hopefully is able to be weaned off, then it's a difficult situation. There's an infection risk. So I don't think that's an appropriate solution. So I would like to introduce to the application of hemopatch on Dacron prosthesis. Unfortunately, this video stopped. However, it makes clear that you don't need viable tissue, human tissue, in order to apply hemopatch. The hemopatch in combination with blood even works on prosthetic material. So now, unfortunately, the patient, after cardiogenic shock, reopening a CTO of the LAD, didn't recover. He had, in addition to his LV impairment, a poor RV function. So we decided to implant the durable LVAD with a temporary RVAD with a plan to wean off the RVAD over time. However, after successful implantation, closure of the chest, patient just arrived on ITU. There was a significant chest wall bleeding, and we had to go back to theater. And of course, if we think about again, oh, patient should not bleed, should not bleed, should not bleed, and then you preach always no bleeding, and then you see this significant chest wall hematoma. And my first idea was, oh my God, it must have been an injury to the LAD or intercostal artery, because I passed the graft through from the pulmonary artery through the intercostal space, passed it down into the area of the subxiphoidal area to just exit the skin. However, it wasn't bleeding from the intercostal artery. It wasn't bleeding from the lemur. It was a nasty bleeding from the sternum, an unbelievable bleeding. So we did extra stitches, and then in the end, we applied a hemopatch even to some kind of the sternum, achieving a good hemostasis of the sternum. Sternum could be closed, and patient went back to ITU without further bleeding. So I come to the end. Voltaire's principle number 4, counter any aggression promptly. Sharks rarely attack a swimmer without warning. Usually there's some tentative exploratory aggressive action. It is important that the swimmer recognizes that this behavior is a prelude to an attack and takes prompt and vigorous medial action. So for us, the take-home message, expect bleeding, be prepared for bleeding, and have the right tools available. And I personally believe the toolbox, which is provided by Baxter, including in particular the hemopatch, is an extremely important tool to react on a variety of different bleeding problems and can help you in a difficult situation, not only COVID in general. So I'd like to thank you for your attention, and I'm happy to entertain your questions. Thank you.
We accomplished heart, lung transplantation, and even quite emergent excision of cardiac tube. In summary, my colleague Smile summarized after phase of travel.
Thank you, Professor Stock, for sharing your experience and insight on how you managed during the COVID period and the fascinating cases you outlined. As before, there will be a quick poll, so if you please take a second to rate the presentation, that would be much appreciated. This now brings us to the Q&A session. As a reminder, if you could please post questions on the Slido platform. We currently only have one question, so we do invite you to ask as many questions as you wish. This is your opportunity to speak to the faculty. So I will give it a couple of seconds for questions to come in.
High risk of low risk of COVID infection. So we kindly survived the first surgery, survived the second.
Okay, so I will go to the first question, and this question is for both Professor Alatar and Professor Stock. So, first question, hi professors, great talks. Are there any strategies developed during COVID times that will have a long-term impact in terms of patient blood management? For example, they will remain despite the decline in COVID-19 numbers. And if we could go to Professor Stock first.
Well, I personally believe the whatever we learned in the COVID period will help us in general, even without COVID, and we hope that COVID is soon over. But I believe meticulous hemostasis is our bread and butter, and once we learned it during COVID, it will help us in our normal career as well.
Thank you, Professor. And Professor Alatar?
Yeah, so I think any good practice should continue and perdure. There's no doubt about it. And while bleeding has been part and parcel of the risks of surgery, any bleeding any reduction in bleeding is, of course, a welcome addition. So I think what we've noticed is while bleeding is challenging, while bleeding is problematic, before COVID, we would go back, patients would be reopened as an emergency. Today, with the preparation, particularly taking into consideration the need for PPE, there are further constraints on our practice. So bleeding is well, albeit a particular complication, it's something that we would actively work against. And I think there is an awareness amongst our colleagues that we will not tolerate bleeding today as we would probably a year or 2 years ago pre-COVID. And I think that definitely is something that's anchored into our practice. So yes, I would hope this is something that would continue as part of our post-COVID world. And Aaron, I just would like, that I had the opportunity to talk. There was a slight mistake in your introduction. I was the previous director of the Scottish National Heart Failure Service. So I just wanted to clarify that. Thank you. Apologies.
These instructions are written primarily for the benefit of those.
Okay, so we'll give it another couple of seconds to see if any more questions come in.
I'd like to ask Uli a question about the hemoshield patch. So I think one of the problems with hemostat is using them, and I just wonder what advice would you give to a novice who hasn't used the patch before? What special precautions, what tips would you share with people who have no experience with this device?
We must not bleed. Tell the patient.
Well, I believe it's a very good question. You need to have a proper training, not only from the surgeon, but from the nurse as well. So if you use the hemo patch without really understanding that the blue needs to show, well, blue to the sky or blue to you, with these little marks, and then if you don't use a dry swab, for instance, and you take a wet swab, then the product goes straight to the bin. So if you have proper training, and then of course what I really appreciated was this live training in Vienna by Baxter, offered by Baxter, where you can really train and get an understanding about the scope. Because if you have severe bleeding and you apply the hemo patch, it won't work. So you need to have some kind of, well, significant bleeding. But if it's going to be underwater or some kind of, well, you're drowning, it's not working. So first you need to do some kind of control the bleeding in general before you apply the hemo patch. But it's a learning curve, and I always encourage my registrars, and first they're hesitating because it costs a little money, but in the end, if you see the outcome of this 21-year-old girl where you have continuous bleeding, and we did 2.5 hours of hemostasis, and in the end it stops. Wow, it's the aha effect. So yes, I invite everyone to really use it, but of course Baxter need to help with the proper application because you don't want to waste it.
I think that's an important message for everyone. These products are available, and I'm sure each and every one of us will be able to obtain them. But the frustrations arise when you don't use them the right way, when the blue is put upside down, and rather than getting hemostasis, you have consistent bleeding, and you think, oh, it's not as good as I was told, or it didn't work so fine. And I think it's the importance, really, of seminars and webinars like this. These are tools. And like any tool, if you don't know how to use it properly, you will be frustrated. You will have you won't have the results that you think others would have achieved with. But I can tell you, as an end user and someone who probably at some point in time wasn't absolutely sure how they were used, those frustrations did arise. And when you don't know how to apply them properly, then you get the exact opposite. There's a great satisfaction of having gone through, well, the 5 Ps, pressure and protamine and platelets, and maybe some sutures as well, and still having that bleeding site persisting. And then finally applying this adjunct and seeing it stop and thinking, that sigh of relief where you know the outcome is going to be positive. And just indeed, like the patient you shared with us, there's a huge, it's over. That difficulty is now over. The next step is getting out of ICU and back to a normal life. And the first step towards that has now been achieved. That operative outcome is now secured.
Absolutely, thank you. And of course, once we are through the lockdown, we will look to return to the wet lab to help with the training on the products. If any attendees do wish to attend, please contact your local account manager who will be able to facilitate that. So we will give it a couple of seconds to see if any more questions come through.
And then in the end, they ask the cardiac surgeon to open the sternum, institute a cardiopulmonary bypass.
We don't appear to have any more questions. So all that remains for me to do is thank you in earnest, our speakers, for providing their time tonight and sharing their valuable insight. I'm sure everyone who attended a great deal, and we will end the seminar here. Thank you, Professor Scott. Thank you, Professor Attar, and have a great final day at the SCTS tomorrow.
Thank you.
Bye.
However,